I'm Dr. Dinesh. I'm DRNB resident. I'm appearing for EDIC exam. So I'm exam going in January.
Okay.
Okay, I'm studying in Kerala.
Okay, great. So I'll take your exams. Basically, I'm Dr. Gunadhar from Apollo Hospital, Navi Mumbai. So this is like 30 minutes total exam. So 20 minutes is for the case and 10 minutes for the CBA station. So additional 5 minutes we'll just allocate in case of any delay or something, but we'll try to quickly finish it up. So whichever questions you don't like know, or you just want to like a little bit you want to take some time, you just let me know so that we can like skip that questions for the benefit of time actually. Okay, and everything will be discussed in your debriefing session, so need not be worried. We'll tell you everything about that. Okay, yeah. So I'll just start with this case. So like there are seven vignette in this case. So just read the vignette, and after that there are certain questions in each vignette so that you can take the questions. So this is the first vignette, like the 46-year-old gentleman with history of road traffic accident, and on arrival to the ER, the patient is drowsy, he is hypotensive, he's quite tachycardic, and there are extensive trauma to the lower limb, right lower limb, and abdominal trauma also. And patient is having GGCS of around 11-12, and after 1.5 liter of fluid, there is only partial recovery, and the blood pressure temporarily came up, but again it dropped to 88/45. So basically so for the questions are like the management of the trauma patients, particularly this patient. So what are the different guidelines you follow, and how do you manage this patient as per the standard guidelines? Just enumerate, and what investigations you would like to send.
Okay. So the guide, this patient is having had a RTA. Right now, patient is in shock. So initial shock after 1.5 liter resuscitation, he is still in shock. He has a right lower limb injury and also abrasions over his abdomen. So its guiding principle will be to start with the primary survey. So I will try to talk with the patient since he is drowsy. So patient straight away will go for airway with C-spine stabilization. Airway, since this patient is drowsy, is GCS of 11, and hypotension, I would go ahead with the intubation with the manual inline stabilization. Breathing, I would like to.
So you follow which guidelines basically? You were talking about which guideline?
ATL.
Can other people remain be mute? Yeah, which guideline this is?
I'm trying to tell ATLS, sir.
ATLS, okay, fine. So what are the different surveys in the ATLS? You are talking about the primary survey, okay.
Yes, sir. Primary surveys. Which one? I didn't understand the question, sir.
No, in ATLS there are different surveys are being described. You are talking about the primary survey.
Yes, sir.
Primary survey consists of what actually?
Primary survey, airway, breathing, circulation, disability, and exposure environment.
Okay.
Followed by adjuncts.
So,
Things will be baseline tests and fast scan, e-fast scan.
okay. Okay. And what constitute the secondary survey?
Start with the history. We take its allergies, medication history, past history, and last meal and events occurring before ending up in that events occurring before the injury. And it will consist of head-to-toe examination. So from head, neck, chest, abdomen, and the lower extremities, bilateral extremities, and the spine, everything has to be done, and it should be again followed up by with other adjuncts like radiological investigations and blood investigations. So in our hospital, we do after a primary resuscitation, we do a CT polytrauma protocol from head to mid thigh.
So what other investigations you would like to send?
So in this patient, apart from the EFAST, I would like to APG to know the get an idea. So in the EFAST, I will look for since this patient is in shock, I will look for any ongoing source of hemorrhage, like in thoracic cavity or in the abdomen, and in the chest, I will look for a pneumothorax and
Okay, got it.
yes, sir.
So, what are your differential diagnosis of hemodynamic instability and shock?
So this
Uh,
patient might have a primarily hemorrhagic shock in an RTA patient. Apart from that, because of the excessive bleeding, that could be definitely a hemorrhagic and a hypovolemic. If this patient had a myocardial contusion and some pericardial tamponade happening, he can also have a obstructive obstructive shock and other shocks.
Other shocks like
Other shocks are distributive and
can it be septic?
at this time, less chances, sir. Patient may have vasoplegia, but not septic shock.
Do you know this term?
Yes, sir. Right. Very
But
less, but I think it is for dividing the patients to locate the care because if the patient's having a imminent death, so these patients may not need full attention, and there are
so
three
how many peaks are being described here? How many
three, sir.
peaks of
Three
the
models.
three? Okay.
Immediate.
So can you tell
Yes,
the
sir.
can you tell the early peak, the cause of death and time, the late peak and delayed peak, the cause of death and time
No, sir.
in trauma patient?
No, sir. I
Yeah.
don't know.
Okay. So now this patient complains of severe pain in the left shoulder and thorax, and he's still tachypneic, and the saturations are 92%, and you can see the breath sounds are normal, and patient is still having tachypnea, and the blood pressure is low in spite of giving 1.5 liter of fluid. ABG is showing severe metabolic acidosis, engulfs and distended neck veins, and you did a EFAST scan, and this is the basically the cardiac window of the EFAST scan. You just describe what you are getting here actually.
XT-wise, examination, he has the three big stride, so muffled heart sounds and elevated JVP and hypotension, and echo parasternal long axis and short axis, and even four chamber, everything is showing fluid around the heart with the collapse of the with the tamponade physiology, and as IVC seems to be dilated.
So this is basically what.
Cardiac tamponade.
Okay. So this is the ECG, and
Pulse is
so how do you
alternate
proceed?
due to
Yeah. So how do you proceed like further?
so this patient so apart from the for the hypotension fluid boluses, so we'll have to call in a we usually call in a cardiologist and try to do pericardiocentesis to evacuate to relieve the tamponade.
So which window you like to
Subxiphoid view we use for pericardio
okay.
patients.
And what are the anticipated complication of this procedure?
There can be injury to the myocardium, so infection risk. So the patient can, if he can again bleeding risk is he can keep bleeding. So
The most dangerous complications of. So
my
what is this procedure? This procedure is called.
pericardiocentesis.
Okay, and this is done by which technique basically? So the technique which you use to do a pericardiocentesis,
Ultrasound guided, we will put it.
ultrasound guided, which technique?
Uh,
Okay.
uh,
So, okay, so what are the complications, most dangerous complications?
So, injuring the myocardium, injuring the lungs, injuring other organs.
Yeah. So
Uh,
injury to the heart is most very dangerous situation. So how do you, like, if the needle touches your your myocardium, how do you like early identify this?
a patient can start getting ECG will show arrhythmias,
Okay.
and
Okay. So
so
the
this
same patients have a different scans. So you can see the abdominal scans and the lung ultrasound. So abdominal scan, you have a splenic, you can see the spleen and the liver and the ultrasound scan of the lung. So can you just describe what is your finding?
So spleen and the liver don't appear to be fully homogeneous. There is likely to be a injury, probably a laceration, or and I can see around the spleen there is some fluid that is collected in the left upper quadrant. So that could indicate bleeding source from the spleen. In the liver also, there are some uh, whitish area. So liver is also injured, and I'm not very sure.
Okay. What are the
And
lung ultrasound source?
lung
Yeah.
ultrasound, the A1 seems to be a profile. B1 has a few B lines. C1 has a diffuse B lines, and D shows shreds, probably a contusion or consolidation.
Okay. So, like in this patient, already you have a patient who is having this kind of lung ultrasound, abdominal ultrasound, but in spite of the fluid resuscitation, blood and blood product, still this patient remain hypotensive and he's in hemodynamic, he's very hemodynamically unstable. So, what will be your next line of management for him?
Apart from the main is the damage control resuscitation, permissive hypotension, hemostatic resuscitation, and damage control surgery. So we'll call in surgical. I will give a surgical consult, and since the if so the damage control surgery within 90 minutes, we'll ask them to control the source of bleeding.
Yeah, so we'll ship this patient to the OT, right?
Yes, sir. Yes, sir.
Okay. So the patient was shifted to the OT, and the surgeon did a great job by doing an exploratory laparotomy. Then he has removed the spleen because of extensive injury, and he has conserved the liver injury. And then patient was shifted back to the ICU. He has two drains, and he has almost received lot of blood and blood products. He has received almost, you can say, 13 units of blood, 6 units of FFP, 6 units of RDP, and lot 10 to 20 units of cryo. And this patient came to the ICU. So what I want to ask you, right, regarding what are this situation called, like this patient who is
Patient has
with
received septic
this.
transfusion due to his ongoing blood loss. Significant volume of blood products.
Yeah, so what is this situation like? You have already sent a the parameters, the HB is low, the
Yes, sir.
TLC is 21,000, platelets are 43,000. So at this point of time,
Could
how do
be
you?
trauma-induced coagulopathy, or even
Okay,
DIC.
okay. How do you evaluate him further?
So
What?
at bedside, we'll do a point of care coagulation testing with a thumb elastograph, and guide the blood product transfusion based on that. And we'll have to keep monitoring hemoglobin, and keep HB hemoglobin more than 7, and targets.
So this is the different take parameters I'm keeping in front of you. So just describe what are these
First one.
take field.
Yes,
Yeah,
sir.
first
First one,
one.
at a normal R time, the K and alpha angle seems to be okay, but there is doesn't seem to be fibrinolysis doesn't seem to be happening. So so that's a normal, and patient can develop the patient is normal. We don't want fibrinolysis to happen. The second one, R time is prolonged, even K and even the alpha angle is decreased. So that can be a sign of coagulation factor deficiency. So FFP can be given. And the third one, R time is prolonged and the maximum amplitude seems to be reduced with the preserved relatively decreased alpha angle. So that could be due to the contribution of platelets or even fibrinogen, mostly platelets. And the fourth one, the patient is having excess fibrinolysis, hyperfibrinolysis, and that could contribute to the bleeding. Yes, sir.
So you just now told about the trauma-induced coagulopathy. Why does this happens actually?
So, trauma-induced coagulopathy, it's due to the tissue factor exposure. The patient can have a hyperfibrinolysis type. Patient can have DIs, the consumptive coagulopathy. Patient can have due to the excessive crystalloid resuscitation, they can have a dilutional coagulopathy also. All these could contribute to the coagulopathy.
Okay. So now this patient remain hypotensive, the drains are hemorrhagic, and he has a decreased urine output throughout the night in spite of giving the fluid boluses, and the abdomen was quite tense and distended, and the lungs, like on auscultation, seems to be clear. The X-ray is also okay, but there is an increase in the plateau pressure and peak pressure, and our other parameters like the urea has gone, the BUN and urea has gone up, and this is the examination finding. You can see the abdomen, the X-ray, and your alarms on the ventilator continuously watching for the high peak and the plateau pressure. Okay, so what is your likely diagnosis in this case?
In this case, this patient is having apparently looking normal X-ray with the high peak pressure and plateau pressure. So there could be a extrinsic, external cause of compression from the abdomen. So either bleeding or excessive resuscitation.
So what is this condition called is?
Abdominal compartment syndrome causing renal dysfunction.
Okay, so how do you proceed
So
like
we'll have
to?
to sedate the patient. Even we'll have to check the intra-abdominal pressure. We'll have to sedate the patient and paralyze them, and the patient should be if the patient is having excessive bleeding contributing to the this thing, the attempt should be made to drain will carefully based on the coagulopathy. And also if the patient seems to be volume overloaded, then diuretics or even RRT can be considered. uh, so uh,
So how do you monitor the intra-abdominal pressure?
Intraabdominal pressure, the most commonly that we use is intravesical measurement. So with the three-port Foley catheter, we connect the stopcock and transducer and instill 25 ml of normal saline, and keep the transducer the level of AS, anterior superior iliac spine, with the patient in the supine position with the patient completely relaxed. At end expiration, we check the intra-abdominal pressure.
Okay. So now your nephrologist, because of the worsening acidosis and drop in urine output, they are planned for renal replacement therapy. And you told your junior to put the SD catheter, 12 French SD catheter was inserted, and just after the placement of the SD catheter, the patient was desaturated, and there are further drop in the blood pressure, and the ventilator again shown you the high peak and plateau pressure alarms. So you've taken an X-ray, urgent chest X-ray, and this is basically the X-ray.
Yes, sir.
So what is your likely diagnosis and how do you proceed?
Catheter was put on the right side. I can see a
Right side, right side.
pneumothorax.
Yeah, yeah.
So pneumothorax, and left side there is extensive infiltrates and probable collapse also. We would left side is more also little better. Right side is the major cause for the excessive
Okay.
plateau pressure. So it has to be addressed. So as how do you classify the condition? Uh, Tension pneumothorax, so obstructive shock. So
Yeah.
man will be to put in a 28 French ICD and connect it to a single.
So does the needle thoracocentesis has any role here?
Yes, sir. So, for diagnosis, for if the diagnosis is unclear and patient is having tension pneumothorax, yes, we and the patient is having worsening shock as well as hypoxemia and very raised pressures, we can do needle thoracocentesis. But since this patient,
Which? Which
Sir,
place, like which place you do the needle?
fifth intercostal space in adults, sir.
Sorry?
Fifth intercostal space in adults.
Okay, fifth intercostal space in this is the recent ATLS as per the ATLS literature.
Yes, sir.
Okay. So after the needle thoracocentesis,
Yes, sir. After
you
we'll have to put in a intercostal drain, 28 French to 32 French
so
will
this
be
fifth
used.
intercostal space in which line? In the middle axillary line, anterior axillary line, or
So,
where exactly?
triangle of safety. So in the since this is a pneumothorax, between mid axillary and anterior axillary line, we can place anteriorly, little anteriorly.
Okay. So how will you critically debrief this incidents to your quality team and to
So we'll have
your
to call
junior
in.
first?
We'll have to call in the patient relatives. We'll have to fully tell the condition of the patient. Tell them what happened, and so for example, we'll have to accept that something got wrong, and remedial measures have been taken, and we'll make sure that it doesn't happen, and this will be
So
taken
there is something, some protocol is there, right?
for bad news delivering, we use Spike's protocol.
So how do you debrief this incident to your quality team?
Well, um, I'm not sure, sir.
So we'll go to the CVS.
Yes, sir.
So quickly we'll finish up the CVS. Okay. So read the scan.
Subarachnoid hemorrhage. If patient is having severe and sudden collapse and P of 3 by 50. And raised, I mean, the gray white cells and gray are ironed out, so cerebral edema also.
How do you differentiate traumatic subarachnoid hemorrhage from the aneurysmal subarachnoid hemorrhage on the CT scan?
I'm not sure, sir.
Not sure. Okay. So what is your next management for this patient? Immediate
So
priority and other treatment measures. Yeah.
priority will be since this patient has a low GCS, we'll have to go in by airway breathing circulation method. So we'll have to my goal will be to secure the airway and to keep normoxia and normocapnia. And circulation, we'll have to keep a little higher BP so that cerebral perfusion pressure is maintained. And we'll have to institute anti-edema, raised ICP measures. So we'll have to sedate the patient. We'll have to keep a normoglycemia. We'll have to institute osmolar therapy with mannitol or 3% saline.
Yeah. What other treatment measures? BP control.
Anti-edema measures. So tired we use, sir.
And
If one tired.
what will be your next intervention, next investigations you'll do for this patient?
ICP
Further
measures.
investigation.
Yes, sir. This is
No, further investigations. You would like to do CT angio to know the location of the aneurysm?
yes, sir. Yes, sir.
Okay.
CT angio.
Identify the graphs. Right
Graph
side and
first
left side.
one.
Left side, identify the equipments, and the right side,
Yes, sir.
left
It's
to
an
the
external
graphs.
ventricular drain. Placed in the lateral ventricle, and it is draining the CSF. And it's draining the CSF.
Identify the graphs on the left side. Three graphs, A,
A
B,
is
and
the
C.
normal wave. B is showing reduced brain compliance, and C the cerebral autoregulation is fully gone, so it is coinciding with the arterial pressure.
Okay. You know about the Brain Trauma Foundation guidelines for indications for ICP measurement?
So particularly no.
Okay.
For
Do you know?
TBI, yes, sir. For TBI, abnormal CT with GCS 3 to 8 and normal CT with GCS 3 to 8 in age more than 40, SBP less than 90, and motor posturing.
Do you know about Lundberg's waves and their different types?
Yes, sir. Yes, sir. Lundberg wakes A, B, C. So A is always pathological. B and C can be sometimes normal. So it's indicating the persistent elevation of ICP.
Okay. This,
Yes, sir.
what does
Uh,
this shows?
Lundberg wave shows sorry, it is optic nerve
This,
parameter.
hmm,
So used to non-initially measure increased intracranial pressure. So
hmm,
and the first one, I think it is transcranial Doppler with
hmm.
suboccipital
Okay.
temporal windows.
So what are the non-invasive ICP monitoring device?
Non-invasive ICP monitoring devices will include optic nerve sheath diameter, transcranial Doppler, NIR, near infrared spectroscopy, ophthalmodynamometry, tympanic membrane measure, acoustic measurement, then PBTO2.
Okay. Okay.
So patient pressure is management of ICP in TBI. So tired approach, tired zero. So securing the airway, patient head and elevation, patient neck in the midline, avoid tying the neck, normoxia, normocapnia, normoglycemia, and sedating the patient, and followed by patient can be instituted with osmotherapy, mannitol 3% NS, and beyond that,
Okay.
will be deeply sedated, yes, sir. 55
Okay. Yeah. So read this and just tell me.
Let's say particular quality where positive was able to follow obviously not on ARTs. So this patient has a headache, neck
Yeah.
pain,
Wait. This is the CSF report.
the pressure is
Comment on the
80.
CSF report.
Yes, pressure is a little on the higher side. Fibrin rib formation. Protein is very high. Glucose is low. White cell count 300 with the lymphocytes. So this patient, being a HIV positive patient, has a lymphocytic
Hmm.
predominant meningitis. So that could vary from a viral meningitis to
Hmm.
tubercular meningitis to
Hmm.
even fungal is also possible. So,
What fungal specifically?
cryptococcus.
Okay. So how to differentiate between cryptococcal versus tubercular?
India ink stain can be done, sir.
Okay. But do you know about aseptic meningitis?
Aseptic meningitis is when there is no blood culture, sorry, CSF culture is negative and counts are low, but other protein is elevated. So that can be seen in drugs intake like NSAIDs, therapeutic agents, even leptospirosis, rickettsial infection like RMSF, and um,
Okay. This
so this is showing uh, trans
MRI of what?
MRI of cervical spine at the level of C5, C6. Uh,
Hmm.
um, there is trans,
Okay.
not
Complete cord transaction.
complete cord transection. Yes.
Not complete cord transaction, complete disjunction of the vertebral, your intervertebral disc.
Yes. Yes.
Okay, and with spinal cord compression. So, how will you intubate this patient?
So since this patient has a C-spine injury, patient has to be intubated with the manual inline stabilization.
Okay.
So complications resulting from such injury, patient can have
Hmm. What kind of complications can arise?
neurogenic shock and spinal shock.
Yeah,
I see.
ठीक. Identify this.
IAP, intra-abdominal pressure measurement, sir.
Okay. At what level will you transduce these equipments?
Mid-axillary line at the level of anterior superior iliac spine.
Okay. Identify the equipments. This is used in trauma actually.
No, sir.
Identify the equipments.
Brain tissue oxygen monitor, sir.
What is the name of the monitor? Brain tissue oxygen. What is the name?
Don't know, sir.
Okay. How do you interpret the results of brain tissue oxygen value? Suppose it tells you that suppose the PbTO2 is 30. How do you interpret?
No, sir. I
Okay.
have.
Okay. Okay, Dinesh. Thank you very much.
Thank you,
Okay,
sir.
we'll discuss again in the debriefing session. So you can log out right now.
Thank you, sir.
Okay. Yeah. Thank you very much. Yeah.